everyone, and thanks for being here today. My name is Kristen Rossler, and I am a physician liaison at Texas Children's Hospital. We are all aware of the current challenges with COVID-19's Delta variant, especially its recent impacts on the pediatric population. Our team of infectious disease specialists are here today to provide an update and answer what questions you may have. Before we begin, please make sure your microphone and video camera are off. We are reserving time for Q&A at the end of the presentation, so if you have a question, please type it in the chat. Also, please note this presentation will be recorded. Please welcome our first speaker, Dr. Stan Spinner. Dr. Spinner is the Chief Medical Officer and Vice President of Texas Children's Pediatrics and Texas Children's Urgent Care. He will provide an overview of today's talk and introduce our panel. Dr. Spinner?
Thank you, Kristen. Good afternoon, everyone. I think everyone knows who I am. I just want to let everyone know how excited I am to be able to introduce our three speakers, all of which are Baylor trained in their pediatric and their subspecialty training. And I will tell you that Drs. Arrington, Marquez, and Dutta have been so generous with their time over these many months answering questions for me, and I think for many of you, as we've worked to kind of go through the very fluid situation with COVID. They've helped us with things prior to COVID, and they'll help us with things after COVID. But again, really want to thank the three of you for your generosity of time and expertise. Dr. Amy Arrington is Assistant Professor of Pediatrics and the Medical Director of the Special Isolation Unit at West Campus. For those of you who haven't seen that, it's an amazing facility. She's also attending at our critical care unit and practices mostly at West Campus. Dr. Lucy Marquez is Assistant Professor of Pediatrics and Associate Medical Director of the Infection Control and Prevention. She's an infectious disease specialist who is primarily at main campus. And Dr. Anki Dutta is Assistant Professor of Pediatrics, Infectious Diseases, and Infection Control, who is primarily at the Woodlands campuses. I believe, Dr. Dutta, are you going to be leading us off? But whoever's going to be leading us off on the talk, certainly I'll turn that over to you. But today's talk will be, again, an update on the Delta variant and the implications for children. So I'll turn it over to you. Thank you.
Yeah, I'm going to let Dr. Arrington actually go ahead and start.
Oh, okay, thank you.
Thank you.
Thank you, Dr. Spinner. We're all three very happy to be here and greatly appreciate your time today. So I will start off and I'm going to talk to you myself about the epidemiology and the clinical features of this Delta variant of COVID-19 and how that's affected children. And we'll look at some national numbers as well as our local data. And then I'll pass it on to Drs. Marquez and Dutta, who will talk about PPE and how to correctly wear that and protect yourself for COVID-19. We'll discuss debunking some of the myths and misinformation regarding COVID-19 and the vaccine, and then discuss the management briefly of COVID-19. So I think when we sit back and think about why are we still in this pandemic, first of all, it's not surprising. You know, we haven't all been vaccinated and all of us, including children, haven't been eligible up to this point to receive vaccines. But to date, you know, this summer, I think the primary reason is the circulation of the Delta variant. And as time goes by and until we get those vaccination numbers up, these variants will continue to, you know, pop their heads within our communities and take over if they are good replicators and strong like Delta has proven to be. Second, I think relaxation of public health measures. So, you know, things get better, the surge goes away, we take our masks off, we stop social distancing, and then the virus rears its ugly head again and we're back at another surge. Along those lines, increasing social mixing. So going back to school has been a big part of Delta's spread within our communities. And then lastly, you know, we still have that proportion of individuals, particularly kids, who are not yet eligible for the vaccine or haven't yet received it for multiple reasons. And so I think we need to look at that not only on a local level, but on a global level as well. So until we vaccinate all of us, you know, there's things that until all of us are safe, none of us are safe. Till our vaccination numbers go up worldwide, then it's hard to shut down, you know, the continuing production of these viral variants, which we'll talk about in this hour. So looking at numbers updated, I think we updated these Monday. This is global numbers, looking at some of the biggest hotspots around the globe. So UK and the United States have definitely been the leaders, especially per million people infected. And you can see, interestingly, on this graph, the UK kind of had their peak, it came down, and then it popped up again, and it's had kind of a multiple surge with this Delta variant. The United States, we'll look at numbers next, is starting to have a downtrend, although, when things get better in the South, the virus tends to move its way up the United States, which we've seen in previous surges. So when we look at US numbers, I like to pull simple data and well-organized data from the New York Times. I look at this every morning, look at our local numbers versus our national numbers. And it gives a nice graphic of not only where we are as far as a nation, but you can look at Texas as well. So nationally, you can see that our numbers are getting better as far as hospitalized patients. So on a 2-week average, we're down about 15% in nationwide hospitalizations. Unfortunately, we've seen this with previous surges, and you can see this both on a national level as well as a Texas state level. Once your hospitalizations improve, you start to see your death rate go up for a while after that surge. And that's where we are today. And additionally, along these lines, when we have that surge that starts to improve for kids, that's at the point when we start to see MIS-C pop up. So about 4 to 8 weeks after your initial infection, we start to see a surge, particularly in MIS-C patients within pediatric institutions. So a lot of this that we're going to talk about today is focused on Delta variant. What is this variant, and how does it look in children so far? So this variant first popped up in India back in the spring, if you'll think back, just the horrendous outbreak that India had. And when a virus can replicate freely in a community, it gets smarter and it learns how to replicate and spread itself faster throughout the population. And we've seen that over time with COVID and the SARS-CoV-2 virus. It's quickly become the predominant variant everywhere. So worldwide, Delta has now taken over. And when you look at the other variants that are out there currently, there's not one that's really capable of giving Delta a run for its money at this point. Research has suggested that it's about 50% more contagious than the Alpha variant, which was the UK variant that we were so worried about, early in 2020. And additionally, that those infected with Delta, even asymptomatically, produce a high viral load within their respiratory passages and their nasal passages. So it can spread the virus easily, even if they have an asymptomatic infection. And what that looks like compared to other variants, compared to the Alpha variant, it's about 10-fold higher. And then compared to the original SARS-CoV-2 strain that was first detected in China, it's about 1,000-fold more than what we saw in the original strain. The CDC has really nice graphics and sites that track viral variants. So if you're kind of a nerd like I am and like to see how this evolves over time, it's really fascinating how quickly something can change within the landscape of infectious diseases. So you can see back in June of this year, orange being Delta and blue being the UK variant or Alpha. It was about 50-50 at that time, and then Delta rapidly took over to where we are here today, where it's really the predominant strain. 98% of infections in the US, if not more, are secondary to the Delta variant. We talk a lot about the R value or R naught of all viruses, but COVID in particular has gotten a lot of press. So where did we start as far as the R? So R number being how well does this virus replicate and how quickly does it spread? So when we looked at the original strain or the ancestral strain of SARS-CoV-2 that first came out of Wuhan, back then we thought that one individual that was infected with the virus could then turn around and infect 2 people. That's, of course, increased over time with each variant and each surge that we've seen. So comparing Alpha on the bottom to Delta back to the original strain, Alpha is thought to have an R value of around 4 to 5, whereas Delta is around 5 to 8. So one person with Delta can infect 8 individuals, which is drastically different than where we started with this virus. And I like this graph because it shows us what it looks like as far as mortality and transmission compared to different viruses. So you can see on the vertical axis here going up is increasing fatality rate or an increasing mortality rates. You see Ebola is on this side at the top of that graph. Ebola, bird flu, and even MERS, which is a similar virus, coronavirus to SARS-CoV-2. And you can see down at the bottom on the x-axis as you go along, you become more infectious. So measles being the far end of that graph spreads much faster. You can see that Delta variant is kind of smack in the middle, equivalent with chickenpox. So very transmissible, especially when you compare that to the ancestral strain, with a decent amount of morbidity and mortality associated with that compared to other viruses. So let's talk about COVID-19 in children and what the Delta variant has looked like. We know for sure, and this data was kind of slow to trickle out, but we know for sure now that kids transmit the virus and they do so very well, especially within households. So there was a nice study that came out in JAMA Pediatrics a couple months ago that looked at Canadian households and children that were infected. So the take home from this paper was that kids can pass that virus along. About 27% of households will have a secondary transmission. So if a child comes home, a quarter of the time those children will infect other individuals within the house, and that's on average 2 people. So really important paper showing that kids actually can transmit the virus, and that can go to other children and adults within a household. I think it's been fascinating to watch what's happened within our school systems, especially in Texas, where we have some schools with mask mandates and others without. And I keep a close eye on the Texas Public School Dashboard, which does a nice job on a daily basis of tracking how many COVID cases have been reported. And of course, that's the cases that are known within our whole Texas public school system. And this website does a good job. You can parse that down to different counties and different school systems. But on a whole, we started out kind of in the middle of August, the first week, with 800 cases of students having COVID and about almost 900 positive staff members. That's teachers and school staff. We rapidly changed those numbers. So the week of August 29th was our highest amount of cases per week, where we had 42,000 COVID cases reported in students alone in the state of Texas. You can see on the left-hand side, the blue, we've definitely started to come down. Last week, we were down to 18,000 COVID cases reported in Texas. And in teachers, we've been seen almost 30,000 cases of adults, whether that's staff or teachers, that have been reported to have been infected with COVID within our school system. So the question remains, is Delta variant actually worse in children than the previous variants? Does it cause more severe disease? So the CDC published a nice study in the MMR a couple of weeks ago that looked at our initial studies from the variant and what we have so far. And I'll say a caveat to this is we don't do an amazing job of collecting data throughout the nation, particularly in Texas, and what we're experiencing and what's reported. But I think these studies show a good trend and really hold up when we'll look at our data in a second here. So comparing before Delta and after Delta, so pre-Delta and post, you can see that the numbers look very similar. So of course, more children were admitted, and we've seen many more children be infected with Delta variant as compared to others. When you look at kids who are requiring ICU care as a kind of indicator here, it's about the same. So about a quarter of kids, 26% pre-Delta and 23% post-Delta, required ICU admissions. About 6% required mechanical ventilation when we looked at things like, for example, alpha strain, and almost 10% required mechanical ventilation when we looked at Delta. So very similar numbers across the board. So these initial data seem to show that Delta is definitely more transmissible among kids, but not necessarily more severe. We do know that we've seen a big increase in children aged 0 to 4 that are requiring hospitalization, actually a 10-fold increase in hospitalization in this younger age group than we saw in previous variants. And of course, those adolescents who are not vaccinated are the ones that we're seeing in our ICUs. So we are not seeing kids that are vaccinated or eligible for vaccine that have received it that are landing in our ICUs for care. So let's look at our Texas Children's Hospital experience across the board and then what we've seen with this variant. So I just took a snapshot of what our census has done since October. I left out the summer surge, but really wanted to show you our January kind of post-holiday. This would be the alpha strain, the UK variant surge, which we thought that was bad at the time, and had much higher numbers than we saw last summer. You can see our surge now, starting in mid-July up till currently. You can see that these numbers are double what we saw from post-holiday, the alpha surge. So definitely a higher transmission rate, definitely more kids that are being admitted to the hospital in this surge. And you can see down here we are today, we're still not back to the highest numbers that we were during the post-holiday alpha surge within our hospital system. So it's without question more transmissible, and more transmission and more numbers, of course, equal more hospitalizations. But is it really worse, and does it cause more severe disease? I'll tell you, I think we have to be careful making those conclusions based on how we feel, and being mid-surge and kind of in the thick of it. It feels worse for a few reasons. I think one is the number of viruses that's accompanied it. So in previous surges, we didn't see the RSV, we didn't see a lot of other viruses circulating at the same time. But I think this RSV season that hit us with these other viruses had made it feel a lot worse, especially juggling our census issues that we've had just trying to find beds for all these children. We're seeing the same high-risk patients, so chronically ill patients, kids with chronic lung disease, whether that's due to prematurity or asthma. Those kids are still at high risk as they've been in previous surges. Older teenagers, of course, who get severe COVID pneumonia tend to do worse, as well as the unvaccinated. And then, of course, obesity has been a common theme of kids, especially older kids who get sicker. They get sicker faster, and they have a much more severe course of illness than children who don't struggle with that as a risk factor. Our experience at Texas Children, if you go back since the beginning of all of this, when we started, our first case, I think, was end of March, the 1st of April. We've seen now over 2,000 hospitalized patients. That does not include the patients that have come in through TCPA, who've come in through our ERs, including all of the PUIs and all of the work we've done caring for those patients. About 23% of cumulative COVID patients, so since the beginning of this, have required ICU care, which really mimics what the national numbers are showing and what the CDC is publishing. If you just look at August and September of 2021, our numbers are a little higher for ICU care. So about 26% on average have required the ICU for this Delta variant. And there were some weeks in August that number was as high as 30 to 32% of patients required ICU care. But all in all, when we take those numbers as a whole, it doesn't really look like the Delta variant is having more severe effects in children as compared to previous. And then, of course, our MISC numbers are just now starting to go up. So over the past couple of weeks, we've seen multiple kids admitted on a daily basis, many of them with multi-organ involvement, and half of those patients have required ICU care. So I think the key to all of this is, of course, continuing to be careful, to social distance, to wear masks, and then to remember and talking to our families about the vaccine, and that the vaccine, of course, isn't a foolproof 100% guarantee that you won't get COVID. But when we look at breakthrough cases, we have had no patients within our ICU at Texas Children's who have been vaccinated patients. So every patient that we've cared for, whether that be because they didn't receive it and were 12 and up, or because they're not eligible, those are the kids that we're seeing hospitalized. And that mimics what we've seen nationwide. So when we look at the fact that we've had over 180 million people vaccinated within the United States, we've seen about 4,400 deaths and about 14,000 hospitalizations, which comparatively, when you think of the large national numbers of vaccinated individuals, that's very low. It comes out to about 0.002% of all COVID deaths are occurring in those vaccinated. And further, when you break down these numbers, of course, 86% of deaths and 69% of those hospitalized are patients over 65 years. So people of older age, people with risk factors, people that, of course, now qualify for the booster shot. So vaccines, I think, are key to getting out of this pandemic. And with that, I am going to pass it on to Dr. Marquez, who's going to talk to you about protecting yourself, and then we'll talk more about COVID myths and vaccine.
You're muted, Lucy.
Thank you, Amy, and thank you for the organizers for having me. So I wanted to spend a little bit of time discussing personal protective equipment, and specifically to address first off that despite the increased transmission with the Delta variant, our recommendations as far as personal protective equipment have not changed, and we still have full faith in if you're using the recommended equipment at the right time and using it correctly, that you have adequate protection from becoming infected when you're caring for your patients. Let's see here. So the next couple of slides have examples of the protocols that we use at Texas Children's, both in the inpatient and ambulatory settings with regard to the minimum personal protective equipment that's recommended in different settings. And of course, in the inpatient setting, we have the luxury of testing all of our admissions and knowing whether patients are positive or negative in a fairly rapid fashion. But really, you can see on this first slide that really for the patients that test negative, that is the only situation in which we are using only a mask and eye protection. And for anybody who is sort of an unknown or certainly positive or has exposures or symptoms, then we are using all of the recommended personal protective equipment, including respirators, gowns, and gloves. Not advancing properly. So this slide here shows our recommendations in the ambulatory setting. And so surely for those folks that work in clinics, you have some sort of screening mechanism to try to identify folks who either may be symptomatic prior to coming to their appointment or have had an exposure. I will in particular try to advocate that it's important, you know, there's always sort of misses that can occur in some of those screening procedures at the beginning of an appointment. And so I think it's prudent as a provider to try to reassess both symptomatology and exposure at the beginning of an appointment, even if the patient sort of screened negative at the beginning, because you guys have probably been in those situations when you get a sort of a surprise disclosure when the patient is in the room about either an exposure or a symptom that, you know, may potentially put you at risk. And then certainly if you have any patients that are undergoing an aerosol generating procedure or an AGP, that would be a situation where we definitely recommend, even outside of symptomatology or exposure, that you use all the personal protective equipment. And so in the outpatient setting, this would be sort of extreme situations that hopefully you're not experiencing too often, such as having to resuscitate a patient. But perhaps sort of lower grade things such as suctioning of airways or administering nebulized medications. Now, I do want to spend some time on eye protection, and this is so particularly important in pediatrics and something that I know institutions struggle with. Because it's burdensome to wear eye protection throughout the day, and there are issues with improperly fitting equipment, fogging, etc. But we in pediatrics have are always going to encounter a population that is unable to either properly mask or mask at all for very young patients. And so that, as healthcare providers, really puts us at risk because the eyes are considered a mucous membrane through which transmission can occur. And so if you have a patient in front of you who is not able to achieve source control by masking themselves, then you definitely are at risk if you're not using eye protection. The CDC recommends that eye protection is used in healthcare settings with what they consider either substantial or high transmission. And so what does that mean? So really, if you are in a setting, in a community setting where there are either 50 to 100 cases per 100,000 population or a positivity rate of 8 or greater, then you should be using eye protection for all healthcare encounters. And so we're certainly living in that scenario right now, although the numbers seem to maybe be improving, and maybe we will reach a point where you know, where our transmission is low enough that we don't have to use eye protection, but in the current setting, it is recommended. And it has a lot of implications in terms of the workforce also, because an exposure for a healthcare provider that did not wear eye protection is considered a higher risk exposure. And so this may lead to quarantine for healthcare providers that were exposed. So it has implications not only on your personal health, but on your staffing in your clinics as well. I'm not going to show these videos, but Texas Children's has published, and they're available on YouTube. You can find them through these QR codes or through these links, both recommended donning and doffing procedures. And that is so critical because having the equipment is probably half the battle. Putting it on right and taking it off in the correct fashion is really sort of critical in terms of making sure that you're adequately protected when wearing them and that you don't contaminate yourself when you're taking them off. And then a quick thing about respirators, I sort of always laugh to myself when I see folks out in the public wearing KN95s and maybe then thinking that they have some sort of degree of protection with these masks that haven't been properly fitted. So you must be fit tested to a respirator, and you must be fit tested to the respirator that are available in the clinics that you have. And so that's very critical, particularly when you're faced with a patient who is confirmed to be positive. To have adequate protection. And then always you need to do a seal test when putting on a respirator to make sure that you don't have any leak. So you sort of press the, if there's a metal in the nose piece, you press that to your face, and you cup your face and you inhale and exhale, and there should not be any leak either when you're inhaling or exhaling. If there is, then this device is not adequately fitting, and you should not rely on that as being adequate personal protective equipment. And then doffing is very critical. I sort of always think about Dr. Arrington when I think about doffing because of the special isolation unit and all the work with Ebola and you know, all the transmission events that happened during the Ebola outbreaks when folks were not doffing appropriately. But removal of the masks really should be, you should really try to avoid any contact with the mask itself and use only the straps for removal. Those are the least likely site to be contaminated, and always do hand hygiene prior to removal and after removal of a mask. And same goes for your respirator. I probably don't have time to get into reuse or extended use of these particular devices, but if you guys have any questions, please feel free to put those into the chat. So we're going to move to the science behind masking in schools. And prior to this lecture, we had sent out some queries to the audience as to things that they specifically wanted to know. And so folks were looking for the science behind masking in schools in order to justify mandated masking. And there's information that exists, and particularly most recently, there have been a couple of studies that have published that really support universal masking in schools. I like this slide. If anybody has performed root cause analyses for a variety of entities in medicine, you've probably come across this Swiss cheese model. And so the theory is sort of that there can be holes in procedures that can happen in hospitals or different mitigating strategies. And so if those holes align, then you end up with the problem. And so here, when we're talking about COVID, you start off with the virus particles, and if the holes align, then you end up with infection. And so there's a lot of mitigating strategies that include both personal responsibilities, such as physical distancing and hand hygiene, cough etiquette, but shared responsibilities as well that include ventilation and vaccination, et cetera. So when we talk about masking in schools, we have to realize that masking itself has its own potential holes because you know, the masking is really reliant on it being properly positioned. Then you have sort of the factors of mask materials, whether you're using a surgical mask or a cloth mask, how many layers does it have, how consistently is it being worn? And so obviously it's difficult to devise this a perfect randomized clinical trial to demonstrate that masks are 100% efficient. But as I'll show you in the next following slides, there are plenty of data to support their use in schools. And it is important to emphasize that universal masking is predominantly the preferred method over voluntary masking. And that's because many studies have shown that masks are probably most efficient at source control as opposed to protecting the uninfected. So that while they do provide some degree of protection to those who are uninfected, it's really the source control that's the issue. And because we know that an estimated over 50% of transmissions occur with people that either are pre-symptomatic or never developed symptoms due to COVID-19, universal masking is really the only way to provide that source control. Considering that need for source control and so many transmission events that occur in those settings, it really only makes sense in schools to mandate rather than to make masking optional. So this first study that I will present here happened in Georgia, and they looked at 169 elementary schools, so K through 5 schools that participated in a survey that looked at prevention strategies that these schools had. And this was done through the latter part of 2020, so obviously before the Delta variant. And they adjusted for county level incidents, and they found that the incidence of COVID-19 was 37% lower in schools that required both their teachers and staff members to use masks. In this same study, there was a trend for student masking as well that was 21% lower incidence of COVID-19, although this was not statistically significant in this study. This is a publication in the New York Times. It was an opinion piece by researchers out of North Carolina who participated in something called the ABC Science Collaborative. They collected data from over 1 million students and staff members in North Carolina from March to June 2021. And at that time, they had over 7,000 children and adults that acquired coronavirus and had attended schools while they were infectious. At that time, North Carolina also had a mandatory mask mandate for all K through 12 schools. And there were, from these 7,000 children and adults that were positive, there were additional secondary 40,000 people who required quarantine because they had been in contact with these individuals, but only 363 additional cases of coronavirus resulted. And so these researchers really advocate for universal masking given that the secondary cases were so low in the population. And then most recently, these two following studies were published just last week. This first one involved looking at K through 12 public non-charter schools in both Maricopa and Pima counties in Arizona. These are the two largest counties in Arizona. And they looked at a period from July 15th to August 31st when schools were opening in the setting of the Delta variant. And after adjusting for potential co-founders, the odds of having a school-associated COVID-19 outbreak were 3.5 times higher in those schools that did not have masking compared to those who had an early mask requirement. And by early mask requirement, that means they had masking at the mandatory masking at the beginning of the school year. And lastly, here's a study also published last week from the CDC. They looked at data from over 520 counties throughout the country, and they looked at counties with school mask requirements. So you can see those ones with those school mask requirements are in the light blue, those without are in the dark blue. And the sort of middle point there was sort of the median start of the school year for all the counties that they looked at. And you can see the difference that after the start of the school year, the rate of COVID-19 cases, even within those counties, the market difference in terms of an increased numbers for those counties in which schools did not have mask mandates in comparison to those who did. So overall, we have data that masking in school works and that it should definitely be pursued. And then I'll wrap up by discussing a little bit about vaccine advocacy in pediatrics. And so in children, I think one of the barriers that sometimes is encountered is the perceived risk. And perhaps the Delta variant, if there's any silver lining, has sort of helped to show that children can transmit the virus and do end up hospitalized. And so, despite, of course, in comparison to adults, the disease severity in pediatrics in general it's much lower, but still children, particularly those with risk factors, have the potential to develop severe or critical disease. And then additionally, even those who had very mild disease have the potential for developing long COVID symptomatology or even MIS-C. And so all of those things are very real risks to children and need to be discussed with families when considering vaccination. So how are we doing in terms of vaccinating our teens in Texas? So the graphic here comes from the Mayo Clinic, and they publish U.S. COVID-19 vaccination rates by age. And you can see nationally, the rate is around 46%. When you look specifically at our Texas numbers in the 12 to 17 age group, we are at around 49.4%. But how are we doing locally? These are data that are specific to Harris County. And you can see that in comparison, Harris County is a little bit lower than our national numbers. But really, truly, these are, here they look at 10 to 19-year-olds. So obviously the 10 to 12-year-old age group is not eligible. But in comparison, our vaccination rates in pediatrics are pretty dismal in comparison to the older populations. And of course, we have to encounter lots of vaccine myths. I personally like to sort of stay on social media and hear some of the things that are out there that I don't necessarily encounter sometimes in my day-to-day routine, just to be informed as to sort of the misconceptions, misinformation that folks have, and to be able to develop, I guess, sort of a counter argument for those things. So, of course, I hear over and over again the concerns for fertility issues, that the vaccine is going to alter your DNA, cause you to test positive, cause you to shed the virus, that they've been made too quickly and can't be safe. And so I don't have enough time to go into all of these, but certainly it behooves us to be informed for all these myths and be able to have honest discussions with our families as to why this is misinformation. And so I will wrap up with one final thing that that has been shown to be a potential side effect in pediatrics, and that's the issue of myocarditis and pericarditis. And so here I have data from the Vaccine Safety Data Link, which includes 9 participating integrated healthcare organizations that collects data on over 12 million persons per year. And they've looked at the incidence of myocarditis in younger populations. And so it's just really important to note, so for both mRNA vaccines, the rate after having a second dose of vaccine is 16.1 per million doses. So very rare event. And when cases have been reported, they have been mild. Some patients have required hospitalization, but they're the only intervention that those rare events have needed have just been pharmacologic therapy for their myocarditis. So whether that's some fluid support or some NSAIDs, there haven't been severe cases of myocarditis as a result. And so because it's such a rare event, and because there have been so many cases of COVID-19 and hospitalizations, all authorities very much are in agreement that the potential benefits of vaccination far, far outweigh any potential risks of vaccination. With that, I will hand it off to Dr. Dutta.
Thank you so much, Dr. Marquez, and thank you all the organizers for inviting us. And I'm shifting gears a little bit because, again, as Dr. Marquez kind of mentioned, these are the questions that were asked for us to comment on. So I'm going to shift a little bit of gears and talk about the testing and quarantine algorithm for schools. And then I'm going to talk a lot about myths that I have heard personally as an outpatient physician at the Woodlands campus about different types of COVID management that are being practiced as an outpatient setting. So this is an algorithm that some of our infectious diseases physician, including Dr. Spinner, has created according to the CDC and the AAP guidelines. And as you could, every school district has their own guidelines, so these are not being strictly followed. But if you were asked as a physician, as an outpatient physician, to provide some guidance to parents if they have been tested positive, then in a few questions to ask, and that's why this algorithm, though I know it's kind of a busy algorithm, but it gives you some answers as to how to approach those answers. So, the two main columns on the left side is the child a close contact, as in, the close contact are both of them universally masking, what is the space between them. So if they're a close contact, yes and no. If it's yes, then whether they're vaccinated, unvaccinated, whether they're asymptomatic or symptomatic. And then, of course, if they're symptomatic, there's no question, they need to get tested. If it's negative, they stay home until 24 hours fever-free and symptoms improving. If they're positive, then, of course, 24-hour fever-free, improving symptoms, plus 10 days since the symptoms first appeared. Now, if they're immunocompromised, that number of days extends to 20 days. This will be available to you if you want to have a look at, the different nuances about vaccination and non-vaccination, and feel free to email me if you have questions. The rest of the talk is going to be about COVID-19 treatment and some myth busters, and maybe, we can provide you some kind of guidance as to how to talk to parents when they ask you about, these treatment options. So the first big one is hydroxychloroquine. I think we have heard a lot about hydroxychloroquine in the press. I still get asked about hydroxychloroquine, but, multiple studies from the WHO, from the Infectious Disease Society guidelines, and the CDC have proven, and this is across the world, not just the United States, have confirmed that hydroxychloroquine does not prevent disease or death from COVID-19. So it is not recommended for COVID-19 treatment. And at some point of time, India was using preventative hydroxychloroquine. And I remember some of my relatives actually buying hydroxychloroquine, and people with rheumatoid arthritis wasn't able to get hydroxychloroquine because it was such a short supply because everybody was taking it. So we want to, have that available for people who really need it. The other one is, of course, a lot of patients have asked me this, micronutrients like vitamin D, C, zinc, are these, helping COVID? And the answer is, again, unfortunately, no. Does it harm them? Probably not. But does it really help to cure COVID? The answer is no. And again, these have been studied in different clinical trials, and they have not been proven to be helpful. The other part is I see a lot of kids who come to clinic who are either on azithromycin or actually Augmentin for COVID. Unless you feel like there is a super infection, like they have a raging otitis media, or they have, some other bacterial infection that's going on, neither azithromycin or amoxicillin clavulanic acid actually help to improve COVID symptoms. And I would just recommend that they be reserved for only if you feel like there is an additional bacterial infection on the top of their COVID infection. And this is the same guidelines for the CDC, the WHO, and the Infectious Diseases Society. The latest one, I think, that I have heard so many times is ivermectin. The FDA has not authorized or approved ivermectin for use. There is a paper, two of my patients, one a hem-onc patient and the other one, a different family, actually emailed me a paper that is going around in the web. And in the title, it says Critical Care Medicine, and it's a meta-analysis. And it puts forward a lot of positive effects of ivermectin in preventing COVID-19 and actually treating COVID-19. Now, if you delve deep into that paper, it is actually has no merit to it. And it's important because, people who are reading these papers, instead of downright saying like, oh, this is all bogus, is to actually read it and kind of see like, what are the points that you can talk to family about, that you can say, okay, this is what they have said, but this is why this is not correct. And most of those studies that were included in that paper, it was very small, few patients, 10, 12 patients, and there's no control saying like, oh, I have done ivermectin on these people and not on those people, what severity of COVID they were. So really not a paper worth, even quoting. So the FDA does not recommend ivermectin. There have been patients who have been using their dogs' ivermectin. Please do not do that. Their dogs' dosing and a human being's dosing are completely different. So please do not ask your vet for ivermectin, and please recommend that your pediatric population definitely doesn't use that. And again, the WHO, FDA, CDC, the Infectious Disease Society have said there's no data to show ivermectin is effective against COVID-19. This is a great resource that you can actually use. This is from Mayo Clinic, but it also is present on the WHO website. And if you want to provide this to your patients, it has at least 20 of myths that I did not talk about, but there are other things like, bleach and sunlight and, mobile phones, plenty of them, like at least 20 of them that's in there. So feel free to use this link and present it to your patients if you feel like this would be helpful. But I thought this was a great kind of short, like 1.5 page kind of myth buster that it can use for patient information. So what are the treatment options then for COVID-19? So this is a very pretty recent article, published in January of 2021 that talked about pediatrics, because a lot of the, the treatment guidelines that we have are in adults, and a lot of it is extrapolated from adults to children. So this was a kind of good summary of what we should do. Especially since, most of you are in the outpatient setting, you're going to see the mild to moderate disease. And as you can see, the first and second disease category are mild to moderate. The severe and critical, so when you're starting to, you have an oxygen requirement, or of course, when you're in, acute respiratory failure, that's when you come to the hospital. But the first two, that's what the most, children are going to have, is no increased oxygen requirement. And you might have a little bit of pneumonia, but otherwise doing great. And both of them, you're going to do supportive care. So for the first two, there is a treatment option. So mostly supportive care, really did not need to do anything. Things will get better just with any other viruses. But the question to ask is, do they have risk factors, right? And we'll talk about risk factors in a little bit. So those are the ones with risk factors. Age group, are they more than 12 years old? And the third thing to ask is, are they more than 40 kilos or not? So if they check all these three boxes, then they can qualify for monoclonal antibodies. What are monoclonal antibodies? This is one of them that Texas Children's has that we are using. So what they do is they block the virus to bind to the receptor. And so it doesn't get into the cell to replicate, right? So it blocks the virus entry. So that's what monoclonal antibodies are. Who do you not use them on? So you cannot use them if they're hospitalized with COVID. You cannot use them if they're already on oxygen therapy. Now we know we have a lot of chronic kids who are already on oxygen. So if they have an increase in the baseline oxygen because of COVID, we cannot use it in those. And why is that? Because they have been shown in children or even in adults, if they have been hospitalized with acute respiratory failure, especially if they're intubated or on high flow, the monoclonals are actually making their disease worse. That's because they produce a huge immune response when you're giving it to them when they're already very sick. So we cannot use it in this group of patient. Only those who have mild to moderate without oxygen requirement. This is key, 12 years or older, above 40 kilos, and do they have risk factors? And these are some of the risk factors that are there. Of course, if they're adults, over 65 years of age, obesity, again, as Dr. Arrington mentioned, huge risk factor. So if you have a child who has no other risk factor but is obese and you think has COVID, he or she may qualify for the monoclonal antibodies. And then, of course, there is chronic kidney disease, diabetes, immunosuppressive state, cardiac disease, chronic lung disease, sickle cell disease, neurodevelopmental disorder, or if they are a chronic kid, as they have a tracheostomy, they have positive pressure ventilation at home. So those are the types of kids, even if they have mild to moderate, would qualify for monoclonal antibodies. So what do we do for hospitalized patients? So this goes into the severe to critical category, and I'm not going to go into too much details on that, but those are three mainstays. So we do use remdesivir on them. We do use dexamethasone on them. And that's another myth. I see a lot of patients who are coming to the clinic with COVID who are oral steroids, but has very mild disease. Oral steroids are not meant for mild disease, unless it's for other reason, like asthma exacerbation or something. So dexamethasone is meant for those patients who are hospitalized and have an O2 requirement and is sick. And then for those critical patients, there are several kinds of interleukin-6 inhibitors that have been used in the ICU, but I do not want to go into more details. If you have questions, please put them in the chat. So I would end so that I have time. We all have time for questions. That this is, again, as Dr. Spinan rightly mentioned, we are always in a fluid kind of mode in the past, 2 years. I know we are all tired. We are fatigued with questions, probably somewhat morally distressed with, a lot of the misinformation and the myths. But we are almost there, and we are, let's be flexible, continue to promote vaccination, get your booster if you qualify, and then, encourage wellness amongst your colleagues, and then stop the spread of germ by practicing all those, wearing a mask, washing your hands, keeping a distance, covering your cough and sneeze. And when the transmission is better, we might be able to, go back to semi-normal state. But for now, let's be vigilant and keep monitoring the situation.